Thank you, Nadine, for that. So good day, colleagues, and thank you once again for making time to join us for another session of Decoding the Science with some of our experts here at the NICD. We are very glad that you could make time for us today, and we hope to really engage at the end of the sessions. I'm sure some of you have seen the program. So today we are going to be focusing on a number of topics, but before we get into it, my name is Sinitla Chimo, and I'm the Senior Communications Manager here at the NICD, and I welcome you all, joined by my colleagues, Dr. Juno Thomas, who some of you might know from the listeriosis outbreak that we dealt with here at the NICD. I'm also joined by Dr. Saeed Rashida, who's a Senior Medical Scientist here at the NICD, as well as Professor Cheryl, who heads up the Center for Respiratory Diseases and Meningitis. So without wasting any time, I'll just ask Dr. Juno Thomas to pop up her presentation as we start. And I just want to remind colleagues that we really, part of these sessions are to really engage with you. So we look forward to engaging with you at the end of the presentation. So you are more than welcome to pop up your questions on the chat, and we'll have the experts address them on this platform or via the chat functionality of the Zoom platform. So without wasting any time, I'm going to invite Dr. Juno Thomas to start with her talk on enteric fever in South Africa. Over to you, Dr. Thomas.
Thank you very much, Sine, and good afternoon, everyone. So first up on the menu today is an old world disease, enteric fever, which I think most people will recognize by its older term, typhoid fever. And I'm just going to give you a little background on what it is. It's not something that comes in, under the spotlight very often. And I think especially over the last few years, we've had the newer novel diseases to deal with. And some of our ancient plagues have taken a bit of a backseat. So enteric fever is a newer term that includes typhoid fever, which I'm sure everyone has heard about, and paratyphoid fever. And typhoid is an ancient plague of humans. It emerged even before we became agriculturalists, in fact, when we were hunter-gatherers. And it's been around in the human population virtually unchanged ever since. It is a potentially life-threatening infection, and it's spread by contaminated food or water. Once you've eaten or drunk the typhoid bacteria, it invades through the gut and enters into the bloodstream. And then it causes a generalized infection throughout the body and can have potentially fatal complications. It is, like many other ancient scourges, a disease of poverty, occurring predominantly in association with poor sanitation and lack of clean drinking water. And this is in both urban and rural settings. So it continues to be a major public health problem in the developing areas of Africa, America, Southeast Asia, and the Western Pacific. And children are characteristically at highest risk for disease and death. In fact, most disease worldwide occurs in children aged between 5 and 15 years. So WHO estimates that anywhere up to 20 million people develop enteric fever every year, and up to about 160,000 will die from it. There is great concern worldwide that the growing rate of urbanization, which leads to mass overcrowded populations in small areas, coupled with inadequate water and sanitation systems, as well as climate change, are going to drive the increase of typhoid fever across many lower middle income countries. And I think ours is no exception. We obviously are experiencing growing rates of urbanization and are experiencing the adverse effects of climate change already. There's also increasing spread of antibiotic-resistant strains of typhoid. And over the last few years, there's been an extremely drug-resistant or XDR typhoid fever strain, and that makes it very difficult to treat these patients, and it also spreads easily as a result. So diagnosing typhoid fever is actually very difficult because the person doesn't present with anything typical. It can be more like a flu-like illness initially, a fever, fatigue, headache, nausea, and some people may also have abdominal symptoms like pain or a bit of constipation or diarrhea. So it can be extremely non-specific, but you can only diagnose it through doing a blood culture, which is obviously an investigation that isn't done at all levels of healthcare, and in many South African healthcare settings is not a routine investigation that would be done. It's typically only done in patients who are sick enough to be admitted to hospital and where there's accessibility to laboratory diagnostics. The problem with typhoid is even if you do develop mild disease and or you develop more severe disease and are treated and get better, you can still carry these bacteria in your gut for many years. In fact, some people carry them in their gut lifelong, and they continue to replicate in the gut and get shed in the stool or the feces. And these people act as reservoirs and can continue contaminating food and water sources. Just like, for example, I think the most famous person who was a carrier ever was Typhoid Mary. So as recently as the early 1900s, enteric fever was still a major public health problem in many high-income countries. For example, in the UK and in many parts of Western Europe. But following the radical implementation of improved water systems and sanitation and hygiene and some other public health measures, it's virtually disappeared in these areas. And they only see typhoid fever in patients who have traveled to endemic countries and got infected there. So the prevention and control is in fact very simple. It mostly relies on having adequate safe drinking water and improved sanitation. But other public health measures are also important. So you need to be able to accurately and promptly diagnose the disease, treat it with the appropriate antibiotics, identify and treat the carriers so that they can't carry on seeding the bacteria into the community. And in some instances, you can vaccinate as well. Food safety is extremely important because you want to prevent anyone who may be a carrier from contaminating foods that are going to be eaten by many people. And health education is also critical. So everyone in every community needs to know how important it is to perform hand washing and also to have adequate food safety practice. And this obviously protects people not only against typhoid fever, but many other communicable diseases as well. So let's turn to enteric fever in South Africa. We are classified as being endemic for enteric fever because we have Salmonella typhi that is continually circulating amongst certain communities in South Africa. So it means that there's a constant presence of enteric fever within our country. So even though we are classified as endemic, we still have a much lower rate of disease than many other countries in sub-Saharan Africa. It is a notifiable medical condition, so it does mean that all healthcare workers are legally obliged to report cases of enteric fever and that there is a standard public health response that must be effected upon notification. But the problem in our country is that the reported cases significantly underrepresent the true number of cases that we have, because it depends on what we call diagnostic practice. So it's how aware is the healthcare worker about the symptoms and presentations of typhoid fever, and how often would that healthcare worker, for example, send the patient for a blood culture to investigate for typhoid fever. And we know that awareness for typhoid fever is extremely low amongst many clinicians in many parts of the country. So they wouldn't even be testing for typhoid fever in the first place. And accessibility of laboratory testing is also a problem in many parts of the country, especially the more rural areas. So outbreaks of enteric fever used to be very common, but the last large confirmed outbreak in South Africa was in Delmas in 2005, where there were an estimated at least 2,900 cases, but likely much more, with the number of deaths not confirmed. And that was linked to contaminated water supply. So if we look at the number of enteric fever cases in South Africa, and now these are cases that are confirmed by laboratory testing, we can see that in general, there are less than 150 cases per year. In 2005, that spike is there because of the Delmas outbreak. Now, not all of the cases in the Delmas outbreak were confirmed by blood culture, but they counted anyone who had the same symptoms and who had links to other people known with typhoid to be cases in that outbreak. And you can see for the last few years, the numbers have been really unremarkable for 2017 to 2021, for example. But when we have a look at the proportion of cases by province for those years, you can see that, I'm not sure if you can see my arrow here, but that the proportion of cases in the Western Cape increased from 2018. They were fairly low and then increased quite steadily year on year until 2021. What's also interesting is that in 2021 and 2022, you can see in the red bars there that the number of cases in Northwest was much higher than it had ever been since we have good data stretching back to 2003. What you can also notice is that generally the most number of cases are diagnosed in Gauteng, which is the light blue bars. And this is for a number of reasons. I think it is because of healthcare utilization and because of diagnostic practice in most of the hospitals within Gauteng. Blood cultures are easily accessible, and there's a willingness to do blood cultures for investigation at these facilities. So I think a lot of it is biased towards diagnostic practice and laboratory accessibility. So I'm sure many of you will remember the listeriosis outbreak of 2017 and 2018, and how we used whole genome sequencing to link the patients together and link the patients that were infected with a certain strain to the food products they'd consumed and the food production facility that produced the contaminated items, and were able to then deduce what the source of the outbreak was and implement appropriate public health measures to stop the outbreak. So what we've done since 2020 is we are using whole genome sequencing to investigate all our cases of typhoid fever across the country. And it's exactly the same principle as what we did with listeriosis. Every isolate gets sent for whole genome sequencing, and then we do analysis to see how related they are at a genetic level. And through that, we can tell where there are clusters of cases. In other words, quite a few cases that are due to the same genetic strain. And then that must mean that there is very likely a common source of infection. And typically, this then means also that there are public health measures that can be implemented to try and stop further transmission. So you can see in purple there, I've circled one cluster, and most of those cases are in orange. And this is a specific cluster in Northwest. Then there are 3 other clusters that you can see there. They're all this dark blue color. And these are clusters in the Western Cape. So we know that there is a cluster, which is in fact an outbreak, which is ongoing in the Northwest, because these isolates are all basically the same strain. And then there are 3 separate clusters or outbreaks in the Western Cape. And what is interesting is these are geographically quite distinct clusters. So, they aren't all occurring in the same area. They're occurring in 3 different districts of the Western Cape. But it does suggest that for all of those different outbreaks, there are different sources or reservoirs, and perhaps even different transmission patterns. And the same goes for the Northwest. What is also interesting is we noted that most of the cases every year come from Gauteng, but if you look at the Gauteng cases, which are each shown in sort of a light purple circle, in fact, they're quite widely distributed amongst the genetic varieties of Salmonella typhi isolates. So there's no distinct outbreak in Gauteng. These seem to be unrelated cases. So obviously, even though there's not a major increase in typhoid cases since 2020, what we can say is that there are distinct outbreaks occurring across at least 2 provinces of the country, and the relevant provincial departments and district departments of health have been engaged in ongoing outbreak investigations to try and discover potential sources of infection and to try and manage the cases properly and follow up on the contacts and carriers to try and reduce the number of carriers in the population as well. And although we know what the basic measures to control these outbreaks are, some of them are very challenging to implement. And of course, there are multiple different governmental stakeholders involved because it spans water, sanitation, health. And there are certainly financial constraints in many districts and municipalities that do make it a very challenging project, for want of a better word. But also in the healthcare sector, we need to raise awareness among healthcare workers to detect cases. We know we're under-detecting them, so we might be missing other outbreaks as well, just because the cases aren't being detected and we're not able to do the genetic sequencing on isolates. And for the general public, I think it's always important to emphasize health education on food safety, hand hygiene, and also educate people about how they can treat water at home or at the point of use when there are concerns about the quality of water supplied. So we know that there are often concerns raised across the country about water quality issues or water supply problems. And I think we need to do more in advocating water treatment at a household level if there is any concern about water quality. And that's very easy to do. It's either the boil, it's what's called the boil or bleach approach. You either boil your water before drinking or before using it to cook, or you can render it safe by treating with a very small volume of household bleach. So thank you very much. That is the end of the presentation. Shall I hand back to you, Sene?
Yes, thank you so much, Dr. Thomas, for that insightful presentation. I just want to remind colleagues to put their questions up on the chat. We'll respond to all of them, but also I've shared a link to the presentations for those who want a copy and for those who joined the session later on. I'm going to move on now to Dr. Saeed Rashida, who's a senior medical scientist here at the NICD. She's going to talk to us about their work that they're doing with regards to wastewater. So her presentation is titled, "How can wastewater monitoring support and inform public health responses to COVID-19? Over to you, Dr. Saeed Rashida.
Thanks, Ine, for the nice introduction. Okay, good afternoon, everyone. So today I'm going to tell you how wastewater monitoring support and inform public health responses to COVID-19. And I'm planning to do that by decoding wastewater testing for SARS-CoV-2. Now, just to give you a brief outline of what I'm going to talk, I'm first going to define what is wastewater-based epidemiology and how it has been useful in tracking COVID-19 across communities throughout the country. Then I will tell you about the South African collaborative COVID environmental surveillance system and what has been the successes of wastewater-based epidemiology in the country so far, what is the most up-to-date information with regard to wastewater testing, and how you can keep up to date with the levels of SARS-CoV-2 in wastewater across the country. Now, people infected with SARS-CoV-2, whether they present symptoms or not, excrete the virus in stool. And even people who present symptoms start shedding the virus before the clinical symptoms appear. Now, the virus shed actually ends up in the sewage system. Now, studies have shown that the levels of SARS-CoV-2 in wastewater reflect population changes in case numbers and geographical distribution of cases. Now, when we record increases in SARS-CoV-2 levels, it has been shown that it appears in wastewater before the numbers of clinical cases rise. Therefore, it is important to monitor changes of SARS-CoV-2 levels in wastewater in order to help support public health preparedness and response activity. Now, I just want to emphasize the fact that SARS-CoV-2 evidence provided so far have shown that SARS-CoV-2 is not transmitted through the fecal-oral route, and SARS-CoV-2 detected in wastewater is not infectious. Now, tracking the levels of SARS-CoV-2 in wastewater, tracking the levels of SARS-CoV-2 in wastewater can help health providers and managers to make informed decisions regarding implementing preventive measures, including health promotion, social distancing, and mask wearing and sanitizing. Now, how wastewater testing can do that, it's if we record that the levels of SARS-CoV-2 in the wastewater is increasing, let's say going from negative to positive, then it actually indicates that the risk is higher for COVID transmission, and health officials should consider changing lockdown levels, reinforce your non-pharmaceutical intervention, implement health promotion, and vaccinate. Now, when the levels of SARS-CoV-2 in wastewater are decreasing, it indicates that the risk is lower for COVID transmission, but still vaccination should be encouraged. Now, tracking COVID-19 through wastewater testing can also be helpful to the public, as it can help them assess the local risk of contracting COVID-19, which in turn will help them make better decisions regarding adherence to social distance, mask wearing, and sanitizing. And again, it does that by showing if the wastewater levels of SARS-CoV-2 increase or decrease, which will indicate that the risk will be higher or lower for COVID transmission. But in both cases, vaccination should be encouraged. Now, the South African Collaborative COVID Environmental Surveillance comprises a network of 8 laboratories, which collect and test wastewater samples from 87 wastewater treatment plants distributed across the country. The initiative is funded by the NICD and the Water Research Commission. Now, just to give you a brief overview of how the testing is performed, we collect raw sewage samples. We concentrate the virus in the sewage samples, extract the nucleic acid, and quantify the virus present in the sample. Now, again, I want to mention that SARS-CoV-2 detected in the wastewater is not infectious. Now, in the next few slides, I'm going to tell you what has been the successes of wastewater-based epidemiology in the country so far, by showing you the results of how we managed to track the virus in wastewater across the country, and how our data showed the early identification of the 4th wave caused by the Omicron variant, and how we also managed to successfully identify the Omicron variants of concerns in wastewater. Now, the graph that you see here on the slide shows you the SARS-CoV-2 levels in wastewater treatment plants from Ekurhuleni North, as well as the laboratory confirmed cases of COVID-19 in Ekurhuleni. Just to give you a brief of direction across the graph, the blue bars that you see here represent the positive clinical cases. On the horizontal axis are the epidemiological week from 2021 to 2022. Now, the colored lines that you see here shows the levels of SARS-CoV-2 in wastewater collected from the treatment plant in Ekurhuleni North. And as you can see, those colored lines peak with the clinical cases. Now, the map you see with darkening color represent the percentage of positive clinical specimen in Gauteng at the beginning of the 4th wave. We found out later that the 4th wave was caused by the Omicron variant. And these maps show how the variant moved from the north of Tshwane into the rest of Gauteng. Now, the graph on your right show the levels of SARS-CoV-2 in wastewater collected at the Rooiwal wastewater treatment plant. The first increase in sewage was detected at week 44, which was about 2 weeks before increase in clinical cases were recorded. Here we have the SARS-CoV-2 levels at a plant in that spot, and the first increase in the sewage was recorded in week 43. Again, before increase in clinical cases were recorded around week 46. These are the levels of SARS-CoV-2 at the RTBS wastewater treatment plant, and the first increase was again recorded in 45, way ahead of the increase in clinical cases. Now, at the Grootkopies wastewater treatment plant, we also detected the first increase around at week 44, but the clinical cases started increasing from week 47. You can see from those results that the levels of SARS-CoV-2 in the wastewater seem to be increasing ahead of the number of clinical cases. Now, what we are trying to define, a minimum threshold that once we reach that minimum threshold, we can alert the public health official. What usually happens with wastewater testing is you wait for 2 consecutive increases before you start raising the alarm. While if we have a minimum threshold, then you can see that we can start raising the alarm from the first increase and minimize the impact of any potential wave of infection. Now, I'm going to tell you how we also successfully identify variants of concern in wastewater. Now, the graphs that you see on the slide illustrate the presence of SARS-CoV-2 variants in wastewater in the top figure and in clinical samples in the bottom figure over time. The horizontal axis in both figures is aligned by epi-week of 2021 and 2022. In the bottom graph, you can see how the variant changed from beta in purple in early 2021 to delta in blue, and then in the third wave, and then to Omicron in orange. Now in the top graph, we picked up the same changes in wastewater. You can see how it changed again from the beta purple in early 2021 to delta in blue during the third wave, and then to Omicron, shows here by the orange dots. Now, at present, the most updated wastewater testing shows that the levels of SARS-CoV-2 has been decreasing after the fourth wave, and the same pattern is observed in plants across the country, as you can see from this graph, showing the levels of SARS-CoV-2 in wastewater across Johannesburg. I just want to draw attention to the blue line, which shows the levels of SARS-CoV-2 recorded at the Goedkoop's wastewater treatment plant, which serves Soweto. However, we did record some few increases in some Gauteng plants. Now, we did, during the fourth wave was caused by the Omicron variant, and the peak is highlighted here in green on the graph you see on the right. Now, we know, and we record the wastewater testing recorded a second small peak highlighted here in pink, which could have been caused by one of Omicron subvariant, maybe. Now, if you want to keep up to date with the levels of SARS-CoV-2 around the country, I would like to invite you to visit the NICD website, where we publish weekly wastewater surveillance reports. Now, we are also currently busy developing a dashboard that will give indicators and graphs with regard to the wastewater level testing. Now, what the dashboard is going to show, it will give you a map, and then you'll be able to hover over a specific area, find a wastewater treatment plant that serves your area, and see how the levels of SARS-CoV-2 in that specific area are either increasing or decreasing. Thank you.
Thank you so much for that presentation, Dr. Rashida. So in terms of questions, I just have a question for Dr. Thomas from Estelle Ellis. Dr. Thomas will take this question after Professor Cohen's presentation. So if you can just check it out on the chat and prepare a response. For now, I'm going to hand over to Professor Cheryl Cohen for her presentation. Over to you, Dr. Cohen.
Thanks, Sine. Can you hear me and see my screen?
Yes, everything's fine.
Okay, so thanks. It's very good to be here today. And I just wanted to give an update in terms of the Omicron epidemiology, and specifically focus on a question related to the different variants and subvariants of SARS-CoV-2. And in our last press conference, there were a few questions about this, so I thought it would be important to give an update. And my talk will really have two parts. The first part will be an update on the epidemiology with a specific focus on what is happening in South Africa right now with Omicron, and a focus on the sublineage BA2, which has been expanding. And then the second part will be really to present data from a new study that we've conducted, focusing on evaluating the severity of this variant, and that study, the preprint has just been posted on MEDX RIV. So there'll be two parts. First, more of the surveillance focus, and then a bit of a an update on severity. So just to give a bit of background on the Omicron variant of concern, I think everyone will be aware now that Omicron, really rapidly was first detected in sub-Saharan Africa, rapidly spread throughout the world, now infecting most countries of the world, and it has very quickly become the dominant variant. Even in places where there was a lot of Delta circulating when Omicron emerged, it's substantially replaced Delta. And what's been interesting is that as Omicron has spread throughout the world, people have been monitoring the genetic sequence of it, and we know that these SARS-CoV-2 viruses, they are always changing and adapting in terms of their genetic sequence, and so not unexpectedly, Omicron, in a similar way to the previous variants, as it became more widespread and spread throughout the world and was around for longer, it started developing into what we call sublineages, which is really, they're all Omicron, they all meet the big definition of Omicron, but they're sort of different versions of Omicron that have sufficient genetic difference between them to be called sublineages. And the important ones are the BA.1, and that's the one that was first identified in South Africa. And at the beginning, I'll show you on the next slide, it was really the dominant variant in South Africa. But very rapidly, another sublineage called BA.2 was identified in many parts of the world. And this sublineage is quite different from BA.1. You can see there, it's got a number of new mutations and some other mutations that are in the BA.1 that aren't in this sublineage. And then there's a BA.3, which is not so important. But the important thing about BA.2 is that in a number of countries throughout the world, BA.2 started to quite rapidly replace the original BA.1. And in some countries, it was also thought to be associated with an increase in case numbers. So there was a lot of global interest in this BA.2 compared to BA.1. And some countries were really quite concerned, about, is the sublineage behaving the same as BA.1 or is it different? And is this difference, of public health importance? Now, the emergence of BA.2 is quite a new thing. So there's not a lot of data out there comparing BA.1 and BA.2. What there is out there is there are a few immunology studies that look at the loss of neutralizing activity, and this is otherwise can be called immune escape. So are people who vaccinated or had previous infection protected against this BA.2? And what they find is that BA.2 has quite a high degree of immune escape, and that's the same as BA.1. So it doesn't have more than BA.1, but it also has these characteristic immune escape characteristics. And there are some data also that look at the transmissibility and that show that BA.2 does seem to be more transmissible, more infectious than the BA.1. And that could be the reason why in some countries it's causing outbreaks, but also why it's replaced the BA.1, because it has this competitive advantage. Now, one question that there really isn't a lot of data on, and which is obviously very important for public health, is the BA.2 more severe than the BA.1? And we know in South Africa, and that'll be the end of my speech, BA.1 Omicron was less severe. And so, but for South Africa, it's really important to know, is the BA.2 more severe? Do we need to be worried about it? So, and that's what I'll talk about at the end of my talk. This slide comes from the NGSSA consortium. Every week we release a slide deck on behalf of the consortium that's posted on the NICD website. And this is really results of all the surveillance for the different variants in South Africa, summarized weekly. And what you can see on this graph, the top graph really just shows the number of sequenced COVID variants or bivariant for the different colors for the different variants. And the bottom one shows of all the sequence variants, what proportion is due to the different variants. And you can see the three waves in South Africa very beautifully, the three most recent waves. Purple is Delta, and then you see purple is beta, and then you see the bluey green is the Delta, and then in the orange and the red you see the Omicron. And you can really see how for each of those new variants, the ones that took off, they're very rapid replacement. And what's striking though, if you look at the orangey red, is that we have different colors for the different sublineages of Omicron. So the BA.1 is the lightest orange, and the BA.2 that we're talking about is the darkest sort of reddy color. And I think it's quite clear the original epidemic in South Africa was the BA.1. You can see, BA.2 in more recent weeks really has, it first remained quite low, but then it's really taken off quite a lot. And it looks like it's coming to really be replacing the BA.1 in South Africa, similar to what has been described in other parts of the world. This is just the same data in another way. It's a pie chart for December. January showing, BA.1, 87% in December, dropping to 60% in January, with the BA.2 coming up to 30%. And the early data from February has BA.2 at 86% prevalence. So amongst all the sequences in South Africa, BA.2 is coming up, and it seems to be replacing the BA.1. What effect is this having on the epidemiology in South Africa? I think what is reassuring is that in South Africa, in contrast to many other countries where BA.2 replaced BA.1, we haven't really seen this replacement to be associated with a substantial increase in cases. You can see here the epidemic curves by province for South Africa, and in all provinces, the numbers are coming down consistently. There is a little bump in cases. I'll focus on that a little bit later, that we did see a couple of weeks ago. So just to show you that that's all the provinces here. It is by age, and you can see here that bump again. And just to focus in, this graph I think shows it best. If we look, these are again cases in South Africa. This is the detection rate. So of all tests done, the percent positive by age, and I think this figure just shows it better, that increase that we saw 2 weeks ago in cases was really an increase in the children of school-going age. So between 5 and 19 years. I mean, you can see it on the previous graph here. This increase is really restricted to the school-going age. So in South Africa, in summary, cases have been consistently going down since the peak around the new year, just before the new year. We did see a small increase in children of school-going age 2 weeks ago, but that we think was mostly really related to the opening of the schools and mixing of children in schools. And you can see that quite reassuringly, the numbers now appear to be coming down. And also we don't see that this increase is shifting to older age groups. So BA.2 might have had some role in this, but it certainly doesn't seem that the replacement of BA.2 has sort of set off a worrying increase in cases. So that's the first part, the updates on the epidemiology. And now I'm going to just take a focus on our research study, which really then tried to look at, we see BA.2 has replaced BA.1. What is the effect of this on clinical severity? And just to highlight that there aren't really data sort of from other countries. There's some early reports, but not a lot of data to really answer this question yet. So this was it's a paper. It's been posted on the MEDX RIV server. It may not be out today, but it will be out in the next day or two. And I think before that, Sine can provide the preprint if people are interested. It's from the same group of authors as our previous study. Now many of you may be familiar. Earlier this year, we published a paper in the Lancet when Omicron first emerged. We saw the very rapid replacement. You've just seen it on the graph. And one of the big concerns was, is Omicron more or less severe than previous variants? And you'll remember that Omicron was associated with this disconnect between the cases and hospitalizations. The cases went high, but the hospitalizations remained low. And we published a paper which showed through data linkage that actually cases of Omicron were significantly less likely to be admitted to hospital and significantly less likely to have severe disease compared to Delta. And so what we did now with the BA.2 replacing, we really had the same question. We wanted to know now, are cases of BA.2 the same severity as BA.1, or are they less severe or more severe? And we used really the same method and the same data linkage to address this question. So just to briefly, we linked the national COVID line list, the lab test data, and then the DATCOV National Active Surveillance Program for Hospital Admissions. And then similar to our previous paper, we took advantage of this thing called S-gene target failure. Now, S-gene target failure is really just a signal on the PCR that can sometimes allow you to tell the difference between different variants and lineages. And you can only use this S-gene target failure if the variant that you're interested in has a mutation in the S-gene target of the PCR test. And this has been very useful for Omicron. So the BA.1, the first variant in South Africa, is characterized by having this S-gene target failure signature on the PCR. And what's very interesting is that the BA.2, which has now replaced it in South Africa, doesn't have the S-gene target failure. So essentially, we can pull in the data of all the PCR tests on this TACPath test from South Africa, and then we can essentially use it to say the S-gene target failure ones are the BA.1 and the non-S-gene target failure or the S-gene target positive ones are BA.2. And using that, we can compare the severity of the two. I think what's very important is this only works when basically all of your tests are Omicron. And in the study period, 99% of all the the sequences in South Africa were Omicron. And so we don't think there's some misclassification or a big misclassification on the S-gene target failure. We looked at two things: risk factors for hospitalization. So given COVID, how likely are you to be hospitalized? And then we did a second analysis amongst hospitalized people. Are people with BA.2 versus BA.1 more likely to get severe disease? And severe disease is defined there. And then very importantly, we controlled for all the other factors that are likely to cause severe disease, like age and province and private sector, etc. And so the adjusted analysis is very important. Otherwise, you can get a wrong result. Our first main result, using this S-gene target failure proxy, we see a very similar result to the sequencing, only it comes a little bit more recently than the sequencing, with really a very rapid replacement of BA.2 with BA.1. So the gray line is the S-gene positive, which is BA.2. And you can see that since week 49 of last year, the BA.1 has gone down and the BA.2 has come up very noticeably. And really what we found in summary is that the BA.2 is associated with a similar risk of hospitalization to BA.1. So when we looked amongst 95,000 people, so a very large sample size, 3.6% of BA.2 were admitted to hospital, 3.4% of BA.1. After accounting for all other factors, these numbers were not different. So very reassuringly, similar to BA.1, BA.2 has the same feature that we saw, that the risk of hospitalization is less than previous variants, and the one we compared it to in the past was Delta. And then the same, when we now look amongst people admitted to hospital, what is your risk of getting severe disease? Essentially the same result. This is a slightly smaller sample, just over 3,000 people. And you see here the BA.2, 30% severe, BA.1, 33% severe. So these numbers, again, after adjusting, are not different. In other words, BA.2, in terms of clinical severity, is behaving very similar to BA.1, with a reduced clinical severity compared to previous variants, and specifically the Delta variant was what we compared. We did have some limitations. We used this S-gene target failure proxy, which can only be used on tests on the Thermo Fisher PCR, so it's not all the cases in South Africa. I mentioned that you could misclassify if there was Delta or other things circulating, but in the period, it was really almost all Omicron. And then there could be a delay for severe outcomes for people to still have the outcome of hospitalization or severe disease. But we censored the data 3 weeks ago. So we've allowed 3 weeks, and we know the vast majority of people who are going to get severe disease already have got it within 3 weeks. And then there are some limitations in our vaccination data. We only have vaccine data for hospitalized people, and it is self-reported. Okay. So in conclusion, Omicron BA.2 is replacing BA.1 in South Africa. We did see a transient increase in cases in children of school-going age, but cases are coming down again. And so it hasn't been associated with a major resurgence. The rate of going down is maybe a little bit flatter than it was before BA.2, so it could be slowing the rate of decrease, but we don't really see any worrying signs of increase. And reassuringly, it's not associated with an increased risk of hospitalization or severe disease as BA.1. It appears to be similar to the BA.1. And these are reassuring data, but we should have caution in extrapolating to other places, particularly other countries where most of the immunity is from vaccination, in contrast to South Africa, where most of the immunity is from natural infection, because natural infection could potentially provide a more robust protection against BA.1 and BA.2 than vaccination. Lastly, to acknowledge many people, firstly, the DATCOV-GEN author groups at the top are the co-authors on our paper, and then also there are a number of other people in the NGSSA sequencing consortium, and many people at the NICD who maintain the different surveillance programs, and also the NHLS that we use for this data linking. Thank you.
Thank you so much, Professor Cohen. So we'll now start taking questions. Dr. Juno Thomas, if you may please take the question from Estelle. I've also noted one more question from Redumeti. Yeah, Juno, you may go ahead.
Okay, thanks. So Estelle was asking for details on where the confirmed outbreaks are, and then if the source of contaminator water had been identified in the cases. So in the Cape, I mentioned that there were 3 separate outbreaks. One is within the city of Cape Town Metro Health District. The other is in the Cape Winelands District. and the third is in the Garden Route district. Then in terms of the outbreak in the Northwest, it's in the Dr. Kenneth Kaunda district. Then with regards the source of, perhaps being contaminated water. So finding possible sources of typhoid transmission, in the midst of an outbreak can be quite challenging because sometimes there are multiple sources of transmission. Remember, I mentioned that you can have carriers that can, result in contaminated food items, and then can also contaminate water supplies. And this can be at a household level, so you can get transmission within the household, but it can also be at a much larger population level. For example, if you've got someone who works in the food industry and handles a lot of food that gets distributed quite widely and eaten by many people, then there's a potential for many people to become infected, from a single case. But then if you have contamination of a water system that serves many, many thousands of people, and it's heavily contaminated, then you'll get obviously many hundreds or thousands of cases quite rapidly. So it can be very difficult to determine the source or the sources of infection, particularly if it's a more grumbling ongoing outbreak, which these are. I mean, as you can see, all of these outbreaks have got cases stretching back already from 2020. So they're established outbreaks, and perhaps now you've got numerous routes of transmission within the community. So in the Cape, for example, for some of the outbreaks, they did extensive water sampling and nothing was detected. And at the moment, the sort of focus is on trying to detect as many cases as possible, following up every case to try and see what any common linkages are in terms of, are they potentially exposed to the same sources of food or water, or have the same contacts in common. And then you want to test household contacts to see if perhaps they may be carriers. And you have to ensure that people who are diagnosed with disease and people who are carriers are treated properly, so that you try and reduce the number of chronic carriers in a population and decrease transmission that way. So what I can say is that all of these outbreaks are being investigated, but none of them are clear-cut. We're looking at multiple routes of transmission and possibly multiple sources of persistent infection in all of these different outbreaks at the moment. I hope that answers your question.
I hope so too. Failing which, Estelle knows how to get hold of us, and we're happy to discuss with her further. I'm going to move on to, and thanks again, Dr. Thomas. I'm going to move on to other questions that we have. Redumete, I'm not sure that your question has to do with science or surveillance. Seems more like a policy question, so I'm just checking if we can respond to it. In the meantime, I have a question for Professor Cohen. There's a question from Anthony, and he would like to know if you can give them an idea of how big the study that you mentioned was.
Thanks, Anthony. I went through it quite fast. So it was a large study because we really brought in cases, all the TACPath cases from a big private hospital group and the National Health Laboratory Service. So there were two analyses. The one where we looked at the risk factors for being hospitalized, that included over 95,000 people. So there were 95,000 cases. And then we looked at amongst those what percent were hospitalized. So that was really a large sample. And then amongst the second one was amongst people admitted to hospitals. So obviously the numbers are less because only a small percent, only about 3 to 4% of people with Omicron get admitted to hospital, but that was still fairly large. So it was over 3,000 hospitalized people. And then we looked at the percent of those that had severe disease. So I think for both of them, really quite a large sample size. And I think we were comfortable, we had sufficient numbers to make a conclusion. I mean, if there was a difference, the sample size was big enough that we should have seen it.
Thanks, Professor Cohen. While you're still on, I have a question from Tamara Khan from Business Day. It's good to see you, Tamara. So to Prof. Cohen, can you elaborate on your comments about why one should be cautious about extrapolating the results on clinical severity of BA.2 to other countries, and explain a little more about how natural immunity versus vaccine-induced immunity plays into this?
So thanks, Tamara. I mean, that's a great question. And I don't have all the answers. I think not everything is known. I think, and if you remember with our original Omicron paper, this was also a caution. I think the first thing we can say is that the reduction in severity that we are seeing compared to Delta and previous variants with BA.1 and BA.2 is likely mediated through two different pathways. And I think there's quite a lot of data coming out on that. There's a fair amount of data that suggests that Omicron may have a reduced intrinsic virulence. And part of this is about the receptors. It's maybe less in the lungs, more in the upper airways. And I think there are other immunologic studies that are still trying to look at this. So it's probably less likely to cause disease in and of itself, the properties of the virus. But we also know, and again, there's quite a lot of data now from different parts of the world, that some of the reduced severity is actually because the vast majority of infections that we are seeing with Omicron occur in people who have had previous infection or previous vaccination, or both of them. And there's a lot of data to show that while Omicron has a lot of breakthrough infections, it's compared to previous variants. In other words, you're not as well protected against getting Omicron than you were for, say, Delta or Beta. Once infected, the protection against severe disease is robust. In other words, whether you're vaccinated or previously infected, if you get Omicron, there's quite a lot of protection conferred against severe disease from those previous immune responses. And so as a result, that's a big player in what we see when we look at Omicron. And in fact, it's quite difficult anywhere in the world to be able to look at sort of the raw severity or transmission or any of these factors anymore, because most people have had previous infection or vaccination. But I think and again, there's not that much data. There are some studies that suggest that there might be differences in the type of immunity that you get from infection with the virus compared to the type of immunity with the vaccine. I think the key answer is both are useful, and both, vaccinations should certainly be promoted and is a much less risky way to get immunity compared to infection. And so we should all, get vaccinated, because obviously the infection can cause death and hospitalization. But in South Africa, we know a lot of people, their immunity is actually from previous infection, and some data, for example, suggests that the protection from previous infection is much more durable and long-lasting. We see quite a lot of waning with vaccine-induced protection, and that's much less with natural infection. Certainly for the previous variants, not so much data for Omicron. Protection from the previous variants was over 9 months out to 12 months, very robust from natural infection, and so it is possible that. And the effect of severity vaccines, could provide a different protection. There's one paper that I referenced in my first slide, and I'm sure Sine will share the slide deck, from Lesenge et al. That was from Scandinavia, where they looked at transmission and BA.2 versus BA.1 with transmission. And it's a very beautiful paper where they show that they could really disentangle, again, some of the increased transmissibility is as a result of the virus characteristics, but some of the increased transmissibility is actually also because the vaccines don't protect as well against transmission and acquisition of infection. And for that, I think natural infection might actually behave differently in that regard. And so and that could be, and there's not data to support this, but in some other parts of the world where BA.2 has come, they've really seen increases in cases, and we haven't really seen that in South Africa. Hypothetically, part of that could be because a lot of our previous immunity is natural infection, and maybe that immune evasion that leads to increased transmissibility of BA.2 compared to BA.1 could be less in our setting. But there's no data on that. No one has studied it, and those are very extensive studies to do. So I'm not sure that such studies will be conducted in settings where there are high levels of previous infection, conferring the immunity rather than vaccination, because you can only do them in settings like the UK or Scandinavia, where you have this very strong infrastructure for routinely, I mean, those countries, they really have databases where every single case is captured and they have the whole immune history, etc., which is not available in many countries which have had a lot of infection. Thanks.
All right, thanks, Prof. Cohen. Can you just quickly answer the question from the citizen? They just want to know if people should continue wearing masks.
Yeah, so I think, I mean, the question about people continuing wearing masks is part of the broader discussion about how can we try and relax restrictions as much as possible while still making sure that we don't relax them so much that we set off another outbreak. We really want to keep COVID under control. We want to keep the schools open, and we want to keep the economy open. And so I mean, a lot of restrictions have been relaxed, but I think it's not quite time to stop wearing masks yet. Masks, there's a lot of evidence now that on a population level, using masks does, on average for each contact, reduce the transmission and acquisition of the virus. And we know in South Africa, vast majority of infections are going to be asymptomatic and they're never going to be diagnosed. And so mask wearing is likely contributing to keeping the numbers low and keeping the numbers going down. I think that we do, however, need to be having a discussion around masks. I think that as things go forward and as we see, hopefully, cases continue to go down, there does need to be a national discussion about mask wearing, and whether some of the restrictions could be lifted, perhaps in a progressive way. But for now, I think, although it's not pleasant, we need to be wearing masks for now. But I think we do need to be having that conversation, along with conversations about a lot of other restrictions going forward.
Thanks again, Professor Cohen. Colleagues, I think we have all the presentations on the chat. If you are interested in a specific presentation, just scroll up on the chat to get a link to the presentations. Puseletso has also been so kind to put up the BA.2 paper that Cheryl was mentioning. If there's anything else that we are missing, please do reach out to me. I'll be happy to send you the resources. Furthermore, we'll also put up the presentation on our YouTube channel. So at a later stage and at your own time, you are more than welcome to check it out on our YouTube channel. I'd like to thank our speakers today. Dr. Juno Thomas, thank you so much for making time. And colleagues are more than welcome to reach out if you've got further questions for Dr. Thomas. And also Dr. Saeed Rashida. It was very interesting to find out more about SARS-CoV-2 wastewater surveillance. We found that very interesting, as well as Professor Cheryl Cohen. So for now, I'd like to thank everybody, and also a very special thank you to our media colleagues for always indulging us and always making time to engage with us here at the NICD. We really appreciate you. I'm going to close off the session until next time. If you do have any ideas or science you'd like us to decode, please let us know. We'll include those topics in our next session. Thank you so much, everyone.